This recorded lecture will be going over Chapter 12, Drugs for Pain Management, in the Introduction to Clinical Pharmacology textbook. Pain is a common problem. It is the main reason why people go to a healthcare provider. Pain can be defined as an unpleasant sensory and emotional experience associated with or resembling that associated with or actual or potential tissue damage. Because the sensation of pain is felt only by the person experiencing the pain, it can be measured only by the individual person experiencing it. The important rule to remember is that pain is whatever the patient says it is, occurring whenever the patient says it occurs, and at the intensity that the patient states. The pain threshold is the smallest amount of tissue damage that will make a person aware of feeling pain. The pain threshold is different for every person and will vary from one body site to another. Most drugs used for pain management will raise the patient's pain threshold. Pain is initially classified as acute or chronic. One of the main features of acute pain is your body's physical response to it. Acute pain will trigger the stress response, also known as our fight or flight response. This will result in an increased heart and respiratory rate, increased blood pressure, sweating of the palms and soles of the feet, dry mouth, and dilated pupils. Chronic pain is any pain that continues beyond the expected time frame of an acute injury process. Some definitions of pain will suggest that this pain must exist for 3 to 6 months to be considered chronic. It does not trigger the stress response because it has been present for a long time and the body has now adapted to it. As a result, the person with chronic pain does not have the physical responses seen with acute pain. Chronic pain may hurt less on some days than others, but usually it is always present to some degree. Chronic pain is often hard to relieve. It may interfere with activities of daily living and can greatly reduce quality of life. Some pain has a constant presence, and other pain will come and go, known as intermittent. Cancer pain is complex and will often require more than one type of drug to manage it. At the spinal cord, the original signal is transferred to a special pain nerve tract and will travel up the spinal cord to the area of the brain where that part of your body experiencing pain is located. The signal would then be transferred to the brain and you become aware of or perceive the pain experienced in one of your extremities. You perceive pain only in the brain, and anything that interferes with the transmission of the pain signal from your toe along to the nerves to and within your brain can change how and whether you perceive the pain. So if you had a stroke that damaged the part of your brain where your toe pain would be perceived, you would not feel that pain. If the pain nerve tracts in the spinal cord were severed, you would not feel the pain in your toe, even though the injury is severe. Although, if the nerves in your leg were severed, the pain signals would not reach the brain and you would not feel the toe pain. Anxiety, depression, fatigue, and other chronic diseases can increase the perception of pain. Activities that distract the patient, create positive attitudes, or provide support can reduce the perception of pain. These non-drug therapy techniques should be used together with analgesics for optimal pain control. Although pain is a common problem, it is often poorly addressed. Ask your patient about pain on a regular basis. Drugs are to be given regularly and are more effective when given before the patient is in severe pain. Assess pain systematically. Believe the patient and family's reports of pain and what relieves it. Choose pain management options that are appropriate for the patient, family, and setting. Deliver interventions in a timely, logical, and coordinated fashion. Empower patients and their families, and enable them to be able to manage their own pain to the greatest extent possible. Analgesic drugs for pain management. Some milder forms of pain can be relieved by non-drug therapies, such as exercise, heat, ice, or cold compresses, music, massage, diversion techniques, sedation and rest, changing the room to be quieter, darker, or cooler, or other methods such as herbal poultice or an acupuncture. Severe pain will require a management strategy using a combination of non-drug and drug therapies. A wide range of drugs are used in managing pain. Some of these drugs are actual analgesics, drugs that have the specific purpose of relieving pain by changing the patient's perception of the pain or by reducing the painful stimulation at its source. The word analgesia means the absence of the sensation of pain. The analgesic categories are opioid agonists, also known as narcotics, opioid agonist antagonists, non-opioid centrally acting analgesics, and miscellaneous analgesics. Opioid agonists are drugs that bind to opioid receptors and provide pain relief. Many drugs used for managing severe pain are opioids. An opioid, also known as a narcotic, is any substance derived from a natural opium or a chemically similar to opium that alerts to the presence of pain and has the potential to induce dependence and misuse. Both natural and synthetic opioids are useful in pain management. All natural and synthetic opioids are high alert drugs because they have an increased risk of causing patient harm if given in error. Opioids and opioid agonists have a relatively high potential for abuse. It's important to learn and follow the rules of medication administration to practice legally. As stated earlier, morphine is the main opioid agonist analgesic, and it is the drug from which all pain management drugs are compared for effectiveness. Morphine and other strong opioid agonists are often used in acute care and hospice settings for patients with severe pain. Hydromorphone or Dilaudid is much stronger than morphine. Human beings can actually make their own internal opioids. The morphine-like chemicals produced in the brain are known as endorphins, enkephalins, and dynomorphins. External opioids that are given for pain relief will also bind to opioid receptors, and they can perform as agonists to activate opioid receptors. The main opioid receptors are named mu, kappa, and delta. Morphine binds most tightly and best to the mu receptor, acting as an agonist. Opioid agonists will change only the perception of pain. They do nothing at the site of injured tissue to actually reduce the cause of the pain. The opioids that provide the best pain relief will bind most strongly or tightly to the mu receptors. The strong opioid agonist analgesics would include morphine, hydromorphone, oxymorphone, and fentanyl. Opioid agonists are used to manage moderate to severe acute pain and chronic pain. They can be used preoperatively to treat pain from injury or other disease processes, for a constant cough, for postoperative pain, as well as for childbirth. Some opioids are commonly available as combination products, along with drugs such as acetaminophen, aspirin, caffeine, and barbital. There are also long-acting opioid drugs that can be given every 12 hours to manage more severe chronic pain, such as cancer-related pain. The two most common side effects of opioid agonists are sedation and constipation. Most patients, especially older adult patients, will have decreased pupil size and are at an increased risk of falling. Serious adverse reactions would include very slow, shallow breathing, also known as respiratory depression, severe hypotension, decreased urine output, below normal body temperature, excessive sedation or coma, and cool, clammy skin. The drug dose should be lowered or the drug discontinued when any serious reaction occurs. If a serious adverse reaction or an overdose occurs with an opioid agonist, the effects can be reversed by giving an intravenous, intramuscular, or subcutaneous opioid antagonist, such as naloxone or naltrexone. Naloxone is also available as an intranasal spray, but this route is not as reliable as the parenteral route. Along with pain relief, decreased pupil size, sedation, dry mouth, and euphoria are the CNS effects of opioid agonists. The effects can be intensified and made worse when the patient is also using other substances that act on the CNS, such as alcohol, anti-anxiety drugs, skeletal muscle relaxants, barbiturates, and drugs used for psychiatric disorders. Tolerance is a drug-related metabolism problem that causes the same amount of drug to have a lesser effect over time. Although tolerance can happen with any drug, it is most often seen with opioid agonists. Tolerance occurs because the body gradually increases the rate at which it degrades and eliminates the drug. Dependence refers to the withdrawal symptoms that can occur when the drug is stopped or a reversing agent is given. Withdrawal symptoms are changes in the body or mind, such as nausea or anxiety, that will occur when a drug is stopped or reduced after regular use. Tapering off can reduce withdrawal symptoms. Psychological dependence, or a substance use disorder or addiction, is a desperate need to have and use a drug for a non-medical reason. The addicted person has a limited ability to control their drug craving or use. Drug misuse is the use of illegal drugs and/or the use of prescription drugs in a manner other than as directed by a doctor, such as using greater amounts, more often or longer than told to take a drug, or using another person's prescription. Tolerance and dependence result from regular use of an opioid for a certain length of time and should not be confused with or labeled as substance use disorder. Substance use disorder is a problem. However, a patient in pain should not be denied pain relief because of the fear of their substance use disorder. All opioid agonists have the potential to cause tolerance and dependence, which are not the same as substance use disorder or abuse, whenever taken on a long-term basis. Opioids are highly addictive because they induce euphoria and cessation of chronic use procedures dysphoria. Chronic exposure to opioids will result in changes to the part of the brain that controls impulse, reward, and motivation. Many different strategies can be used to decrease narcotic use. Before a patient can be effectively helped with pain relief, it is important to determine the cause and intensity of their pain. So it is very important for you to know the cause, intensity of the pain in order for it to be managed appropriately. Ask your patient whether or not they've ever received morphine or another opioid agonist in the past, and what, if any, problems occurred with its use. When opioids are first prescribed, ask the patient about any current tobacco and alcohol use, past substance use disorder, drug misuse, or any family history of substance misuse. When the patient asks for another dose of the prescribed opioid agonist, check to see whether the patient has received his or her most recent dose to determine whether or not another dose can be given at that time. Check the prescribed drug name and dose carefully before giving it to the patient. Opioid agonists are not interchangeable because drug strength does vary. Only the prescribing healthcare provider is able to change the order. If this is the first dose of an opioid agonist that the patient is to receive, be sure to check their respiratory rate and oxygen saturation before giving the drug, because these drugs can cause respiratory depression. This action is especially important when administering to older adult patients or those receiving higher dosages. Usually, opioid agonist analgesics will begin to take effect in 15 to 30 minutes. Check the patient at that time for pain relief and changes in their respiratory rate and depth. Recheck them at least every hour. Opioid agonist analgesics can slow the respiratory rate and decrease the cough and sigh reflexes. Patients who have had surgery, especially those who may have smoked for a long time, can develop areas where the lungs do not inflate well, or where fluid can collect and pneumonia may develop. If pain relief is not obtained or is not sufficient to keep the patient comfortable, report this to the prescriber so that changes in the pain management plan can be made. Higher doses and/or more frequent dosing might be needed. If the patient has been receiving an opioid agonist for 2 days or longer, ask them about any constipation, because this is a very common side effect of these drugs. If stool softeners or laxatives have been prescribed, give them as ordered. Tell your patient and family the following. They must take the drug as prescribed and do not change the dosage. Do not take any other drugs prescribed by your healthcare provider. Alcohol will increase the effects of the drug and should not be taken at the same time as the medication. Report any new symptoms or problems to your healthcare provider. Change positions slowly to prevent dizziness and falls. Do not drive, operate heavy machinery, or make any important decisions while under the influence of this drug. Increase fluid and fiber intake to prevent constipation. Use prescribed stool softeners or laxatives to prevent severe constipation. Take oral opioids with food to prevent nausea. An opioid agonist-antagonist analgesic is a pain management drug that has mixed actions at the opioid receptor site. Although these drugs are not as strong as opioid agonist analgesics, they are thought to have a lower risk of substance use disorder or abuse due to their side effects. 4 opioid agonist-antagonists are available for pain relief. An agonist-antagonist is a drug that binds to a receptor that produces pain relief, and then binds to another receptor that does not produce a physiologic effect. This action will make them less effective for pain control compared to pure opioid agonists. Opioid agonist-antagonist analgesics are used to relieve mild to moderate pain. They are less useful for severe pain. Common mild side effects are similar to those for morphine, and they would include sedation, constipation, and constricted pupils. Higher doses of these drugs are associated with nightmares and hallucinations. The opioid agonist-antagonist can cause serious cardiac reactions. They should not be used in patients with suspected heart attack, and they should be used carefully in those with heart failure. Although respiratory depression is possible with these drugs, it is not common. Use of these drugs in a patient who is physically dependent on opioid agonists should be avoided. The sedating effect of these drugs is made worse with alcohol, anti-anxiety drugs, skeletal muscle relaxants, barbiturates, and many drugs used for psychiatric disorders, as well as pure opioid agonists. Be sure to determine what other drugs the patient is taking. Assess the patient's pain in the same way as you would for an opioid agonist or other pain management route. Be sure to ask what over-the-counter and prescribed drugs the patient has taken within the past 24 hours, especially any opioid agonist analgesics. A non-opioid centrally acting analgesic is a drug that works in the CNS to help manage pain, but does not interact with opioid receptors to do so. The 2 most commonly used drugs within this class are clonidine and tramadol. Clonidine is an antihypertensive drug, most commonly used to lower blood pressure. It works for pain management by binding to specific receptor sites in the spinal cord and blocking their activity. Tramadol has only weak effects at opioid receptors. Instead, it works by blocking the action of some neurotransmitters in the spinal cord and areas of the brain. This reduces the pain signal transmission to the area of the brain perceiving pain. Clonidine is formulated for pain management and is approved for severe pain, most often cancer pain. This can be given as a continuous epidural infusion. Tramadol is an oral drug used for moderate or moderately severe acute pain. Clonidine will dilate blood vessels, which can lead to severe hypotension. It should not be used in patients with low blood pressure. Tramadol has mild side effects of sedation, dizziness, dry mouth, and constipation. Tramadol can induce seizures and should not be used in any patient who has epilepsy or any other neurologic disorder. The sedating and other CNS effects of tramadol are made worse with alcohol, anti-anxiety drugs, skeletal muscle relaxants, barbiturates, and many other drugs used for psychiatric disorders and opioid analgesics. Be sure to determine which other drugs the patient is taking. For tramadol, determine if the patient has a known seizure disorder or any other neurologic problem. If so, you should hold the dose and notify the prescribing provider. Acetaminophen is a common drug used for pain relief. Acetaminophen acts only in the brain to reduce the production of prostaglandins, a chemical that can cause inflammation in other body areas. Acetaminophen alone can be used to manage mild to moderate pain. It can be used for infants and children to reduce fever. In combination with other pain-controlling drugs, acetaminophen can help manage more severe pain. It is often used in the place of aspirin or NSAIDs for pain because acetaminophen will not increase the risk of bleeding. Children should not take aspirin because of its association with the development of Ray's syndrome. The usual adult dose is 325 to 650 milligrams every 4 to 6 hours, and this should not exceed a total dose of 4 grams per day. The maximum total daily dose for children will vary according to the child's weight. Side effects of acetaminophen are rare when taken at the recommended dosage, although an allergic reaction is always possible. The most common side effects are nausea and skin rash. Although acetaminophen is available without a prescription, it can have serious adverse effects. When taken at higher doses for prolonged periods, acetaminophen can be toxic to the liver, resulting in liver damage. The potential for liver toxicity is why there's a maximum total daily dose for this drug. Liver damage will occur more rapidly when acetaminophen is taken with alcohol. Carefully check the strength to ensure the correct dosage, especially for infants and children when administering liquid acetaminophen. If you are not sure of your dosage calculations, check with the healthcare provider or pharmacist. Acetaminophen can be given with or without food because it does not increase the risk of stomach ulcers. Within 1 hour of giving acetaminophen, assess the patient's pain level to determine the effectiveness of the drug. Tell the patient and the family to take the acetaminophen as prescribed and not to alter the dosage. Many over-the-counter sleep aids and drugs will contain acetaminophen. It's important to make sure that you are not exceeding the maximum daily dose. To prevent liver damage, do not drink any alcoholic beverages on days when you take acetaminophen or a drug that contains acetaminophen. Miscellaneous analgesics are drugs that have specific uses for other health problems but can provide relief for certain types of pain. These drugs can help reduce a person's perception of pain and often enhance the pain management effectiveness of other analgesics. They can be used alone or in combination with opioids. The most outstanding feature of non-opioid analgesics is that they are not chemically or structurally similar to opioids. As a result, they have less potential for dependence and misuse. Regardless of category, nursing responsibilities when giving non-opioid analgesics are the same as those described for opioid agonists. Pain assessment and determination of effectiveness in managing pain is necessary. Corticosteroids are drugs with powerful anti-inflammatory actions that are chemically similar to the glucocorticoid hormones secreted by the adrenal glands. These drugs are able to greatly inhibit the production of mediators that result in the actions and symptoms of inflammation. The two most common oral corticosteroids used for pain are prednisone and methylprednisone. NSAIDs are non-opioid analgesics that have the main action of reducing inflammation. NSAIDs can help manage pain associated with inflammation, bone pain, cancer pain, and soft tissue trauma. Like corticosteroids, NSAIDs actually act in the tissue where the pain is starting and does not change the person's perception of pain. With inflammation being reduced, the pain is reduced. All NSAIDs will work in the same way and have many of the same adverse effects. The most common NSAID in use today is aspirin. This is available over the counter. A side effect of aspirin and many other NSAIDs is an increased risk of bleeding. Other adverse effects would include irritation of the stomach and intestinal tract, allergic reactions, and asthma. Stronger NSAIDs can raise blood pressure, increase the risk of heart failure, cause fluid retention, and damage the kidneys. A skeletal muscle spasm is an unwanted overcontraction of one or more muscles. A skeletal muscle relaxant is a drug that can reduce the skeletal muscle spasm by depressing the central nervous system. The most commonly prescribed muscle relaxants are methocarbamol and cyclobenzaprine. Skeletal muscle relaxants are used for pain and insomnia when excessive skeletal muscle contractions or spasms contribute to these problems in adults. These medications are typically not used in children. Common side effects of methocarbamol are flushing, low blood pressure, slow heart rate, and fainting. Common side effects of cyclobenzaprine are dizziness, headache, dry mouth, blurred vision, and urinary retention. Serious adverse effects of methocarbamol are a high risk of allergic reactions and a temporary memory loss. This can also lower the seizure threshold. Serious adverse effects of cyclobenzaprine are cardiac dysrhythmias and prolonged cardiac conduction. The sedating and other CNS effects of these drugs can be made worse with the use of alcohol, anti-anxiety drugs, skeletal muscle relaxants, barbiturates, many drugs used for psychiatric disorders, and opioid analgesics. Be sure to determine which other drugs the patient is taking. Before giving a muscle relaxant to a patient for the first time, assess their level of consciousness, cognition, and their skeletal muscle reactivity. Before giving the first dose of cyclobenzaprine, assess the patient's blood pressure and radial and apical pulses for any skipped beats, extra beats, or any type of irregular heartbeat. See the purple tips for safety on page 234. Assess your patients for cardiac irregularities before giving cyclobenzaprine. If you find any persistent heartbeat irregularity, notify the healthcare provider before you give the drug. Patients will often become very drowsy and can fall when given these medications. Be sure to raise the side rails and remind the patient to call for help before getting out of bed. Help the patient change position slowly because these drugs can cause a sudden lowering of blood pressure. Methocarbamol and cyclobenzaprine can cause urinary retention. If a patient is receiving one of these drugs, has an enlarged prostate, or is also taking a drug for an overactive bladder, be sure to assess for signs and symptoms of urinary retention. Symptoms would include difficulty starting the urine stream, a weak urine stream, and a bulge in the lower abdomen. After giving the first dose of cyclobenzaprine, assess the patient's radial and apical pulses hourly for any skipped beats, extra beats, or any type of irregular heartbeat. Tell your patient and family to take these drugs only on a short-term basis. They are typically only prescribed for 2 to 3 weeks due to their potential for abuse. As for any substance that causes sedation, they must avoid operating any dangerous equipment, driving a car, or making critical decisions while under the influence of these drugs. They should avoid alcohol because the sedation effect of these drugs will be potentiated by alcohol. If you are taking cyclobenzaprine, you must take your pulse daily and report any new onset or persistent irregularities to your healthcare provider. Antidepressant drugs that improve long-term sense of sadness can also reduce some types of chronic pain and cancer pain, especially neuropathic pain. The oral doses of these drugs for pain management will often be different than the doses used to manage depression. These patients must take an antidepressant for 1 to 2 weeks before they will feel any relief from their pain. Anticonvulsants are drugs that work in the brain to reduce seizures. Some have been found to reduce neuropathic pain and migraine headaches. The doses for pain management are often higher than the doses used to manage seizure disorders.